Today I'm going to be talking to you on a very important topic about CTEPH or chronic thromboembolic pulmonary hypertension. I'm going to be talking about the imaging paradigm when it involves multimodality imaging, how we look at CTEPH and how we treat these patients. To begin with, my objectives are to clarify the difference between PH and PAH or pulmonary hypertension and pulmonary arterial hypertension. Then we're going to have a quick look at the causes of pulmonary hypertension and the classification of pulmonary hypertension. Then we're going to concentrate on multimodality imaging of CTEPH and what does each modality provide in terms of patient management. Finally, I'm going to be talking about some of the pearls that we have learned over the years of experience and in terms of how it is managed. PH or pulmonary hypertension and PAH or pulmonary arterial hypertension are often interchangeably used without actually knowing the real difference between these. And it is very important for you to know that these two are actually different entities with different management plans. Pulmonary hypertension is a broad classification of different pathologies which lead to increase in the pressure within the pulmonary vasculature. It is characterized by an increase in the mean pulmonary arterial pressure of 20 millimeters of mercury and a pulmonary vascular resistance of more than 3 Wood units. Pulmonary arterial hypertension, on the other hand, is a subclassification or one of the etiologies of pulmonary hypertension whereby there is abnormality of the pulmonary arteries, where there is thickening and hypertrophy of the pulmonary artery muscle, which leads to increased pressure, and that leads to pulmonary hypertension. So, pulmonary artery hypertension is a pathology at the level of the pulmonary arterial wall, which leads to pulmonary hypertension. On the other hand, pulmonary hypertension is multifactorial. It can be secondary to pulmonary venous abnormality, it can be secondary to pulmonary lung abnormalities, or even shunts that we talk about. So, CTEPH, which we say chronic thromboembolic pulmonary hypertension, is not chronic thromboembolic pulmonary arterial hypertension. So, CTEPH is PH but not pulmonary arterial hypertension. Pulmonary hypertension has been classified into 5 specific groups. Today we're going to be concentrating on group 4, which involves CTEPH. It is one of the diseases which is curable by either surgery or medical management and often has good prognosis if the disease has been picked up early and proper therapy has been given. So what is CTEPH and when do patients get CTEPH? Usually patients tend to have an acute pulmonary embolism. It's either related to a prothrombotic factor or it is secondary to a DVT in the lower limbs which migrates into the lung. This, if is very well treated with fibrinolysis or if it is treated with good anticoagulation, often resolves without much problem. But if there is incomplete resolution of thrombus, this leads to blocking of the vessels, which again leads to vasculopathy or abnormality within the vessel wall, and that leads to pulmonary hypertension. So, acute pulmonary embolism, which is not fully resolved, keeps getting organized over a period of time and starts to increase the pulmonary pressures in these patients. This eventually leads to RV dysfunction and is often a cause of death in these patients. When it comes to CTEPH, what is expected of imaging? First and foremost, it is important that we confirm that the patient has chronic pulmonary embolism and not an acute pulmonary embolism because the therapy is different. Secondly, make sure that there are no other causes of pulmonary hypertension in the patient which is complicating the whole issue. That is followed by ascertaining the severity of pulmonary hypertension, because if the pulmonary hypertension is severe, you know that they may need a surgical management, while if the pulmonary hypertension is not that bad, they often do well with medical therapy. It is important to locate the pulmonary embolism, whether it is at a lobar level, whether it has a branch pulmonary artery level, or distal segmental and subsegmental disease, because this will make therapy different for these patients. Finally, it is important for imaging to provide various prognostic parameters which will help in determining how to treat the patient and to give the patient clear information of what to expect in future. Let's look at the multimodality imaging approach for CTEPH. First and foremost, chest radiograph. Chest radiographs are a great modality if you have severe pulmonary hypertension, where you can see these large central dilated pulmonary arteries, and you will see very poor flow in the peripheral lungs in cases of peripheral pruning. This, however, is not what is usually seen in CTEPH. In CTEPH, the blood vessels are much smaller in size and they tend to taper with not much of flow at all distally. But X-ray is useful to detect the presence of pulmonary hypertension and to differentiate CTEPH from other causes of pulmonary hypertension. One thing which I would like all of you to learn is to see from this image to look for the central pulmonary artery. So you can see this is a central pulmonary artery here. You can see the lower lobe branches and the upper lobe branches. And then you see this vessel here. The lung also looks a little hypoplastic, and this vessel is much smaller than the other side. This is what is called as a Westermarck sign, where you lose the central pulmonary artery secondary to chronic thromboembolic disease in these vessels. So always look for central vasculature on a chest radiograph to make sure that there is no occlusive disease. The next important modality comes is echocardiogram. Echocardiogram is fantastic in assessment of the right ventricular dynamics, especially to see, as you can see here, dilated right ventricle. The interventricular septum is pretty much straightened and to an extent bulging into the left ventricle. The right atrium is also grossly dilated in this patient, and when we do color Doppler, you can see that there is severe tricuspid regurgitation. All of these pointers are towards a RV dysfunction and underlying pulmonary hypertension. So echo will help us in assessing the RV dynamics and also give us an estimation of the pulmonary arterial pressure in these patients. To get a good quality scan, you need contrast within the pulmonary artery so you can tell whether there is acute or chronic pulmonary embolism and the true extent of disease. You also need contrast in the aorta to look at the collaterals, because collaterals are a feature of chronic pulmonary embolism and not seen in acute pulmonary embolism. You also need to cover up to the bottom of the kidney to ensure that the livers are normal and there is normal venous drainage into the liver rather than any portosystemic collaterals or shunts, which can explain for pulmonary hypertension. Also, people choose between a single run or a double run, whereby once you give the contrast, first run covers pulmonary arterial opacification, while second run covers pulmonary artery as well as aortic opacification. We prefer to do 2 runs because it gives us very good information with regards to the bronchial artery collaterals and helps us in differentiating in situ pulmonary thrombosis or pulmonary hypertension secondary to idiopathic causes from those of CTEPH. Finally, you need to look at the lung parenchyma also to make sure that there are correlating features such as mosaic perfusion, which is seen in CTEPH, and whether there are any acute or chronic infarct related findings. So when you're analyzing a CT, the first thing I do is to look at the CT and say, is there pulmonary hypertension or not? To do that, you measure the size of the pulmonary artery. A pulmonary artery which is bigger than 3 centimeters or bigger than the adjoining aorta is suggestive of underlying pulmonary hypertension. We look at the size of the right ventricle in correlation with the size of the left ventricle. The right ventricle is usually smaller than the left ventricle, and if that ratio is reversed, again a feature of pulmonary hypertension. Also, look for reflux within the IVC and the hepatic veins, which is another feature of tricuspid regurgitation. So all of these put together suggest underlying pulmonary hypertension. One tip when you're looking at pulmonary embolism, often we like very good contrast opacification within the vasculature. But when you're looking for chronic pulmonary embolism, you need to change the windowing of the patient. So rather than this bright, it is much grayer, so you can see these webs of filling defects within the pulmonary arteries. One other poor prognostic feature which can be seen in CT is the bowing of the septum towards the left side. When the right ventricle enlarges and the septum is bowing to the left side, it usually indicates that the pulmonary arterial pressure is more than 67 millimeters of mercury. Differentiation of acute pulmonary embolism from chronic pulmonary embolism is very important. In acute pulmonary embolism, you will see expansion of the vessel with a central filling defect, which tends to make an acute angle with the vessel wall. In chronic pulmonary embolism, the vessel becomes much smaller or attenuated, and you may not even see any contrast flow within it. The filling defect often makes an obtuse angle with the walls of the vessel. Collaterals are often seen in chronic pulmonary thromboembolism rather than an acute disease. Mosaic perfusion is often seen in chronic pulmonary thromboembolism, and acute infarct or wedge-shaped opacities are often seen in acute pulmonary embolism. So these parameters are important in differentiating acute from chronic pulmonary thromboembolism. Let's look at this case here. This is a patient who has come in with increasing shortness of breath, some past history of pulmonary embolism, been anticoagulated, and this is the first run that we have done. You can start seeing in this there are these filling defects within the lobar and segmental pulmonary arteries where you're seeing web-like defects in keeping with chronic pulmonary embolism. Let me just show this again to you. As we go in the opposite direction, what you can see here, first and foremost, the pulmonary artery is dilated in comparison to the aorta. Then we look at the right ventricle in comparison to the left ventricle. It looks okay. We look for tricuspid regurgitation, and you can see that there is tricuspid regurgitation of contrast. Next, we are going to look at the pulmonary arteries. Let's look at the left lower lobe, and as you can see here, as we go into the left lower lobe, the vessels are becoming attenuated, very small in caliber, and you start to see some filling defects. On the right side, you can see this, that there are web-like filling defects within the right lower lobar artery in keeping with chronic pulmonary embolism. You see that there is not much contrast in the aorta, so we do a second run, and this is what the second run looks like, where you're getting decent amount of contrast in the aortic system also, and now you will start to see these collaterals around the tracheobronchial tree in the mediastinum in keeping with chronic pulmonary embolism. So if I just pause this and show you the same thing again, what you will see across here, these are the collaterals that you're seeing across here. These are supplying the lung parenchyma, and again we can see the chronic pulmonary embolism in the patient in the lower lobes in there. Another case where you can see the same findings, similar things, where the pulmonary artery is grossly dilated. We look at the left lower lobar artery, you start to see these web-like filling defects. You can see the same filling defects on the other side as well, where you're seeing severe attenuation or the vessels becoming smaller, and there are these webs and flaps within the vasculature suggestive of chronic pulmonary embolism. The right ventricle is dilated, you're seeing right ventricular hypertrophy, the right atrium is also dilated, all pointing towards severe pulmonary hypertension in this patient. Dual energy imaging is extremely helpful in some of these cases where there are subtle clots, and you will see normal perfusion in the lungs followed by large areas of hypoperfusion and then some patchy peripheral areas of hyperperfusion. These often are helpful if you're not able to see the clots in the pulmonary vasculature or you're not getting good quality images. Then dual energy pulmonary angiography is extremely useful. The next modality of imaging that we can use for evaluation of CTEPH patients is catheter angiography. This is one patient whose CT we've just seen, where you can see the catheter is being placed in the left pulmonary artery, and as the contrast comes through, you can see these areas of narrowing in the pulmonary vasculature. I'll just show that to you again. You will see these areas of narrowing in the pulmonary vasculature across here, in keeping with the webs that we have seen in the previous angiogram. Again, CT is also useful to recreate such similar images where you can see in a 3D reconstructed data that there is webs and flaps with very poor flow in the distal pulmonary arteries in these patients. VQ scan or ventilation perfusion scan are also extremely useful, especially in patients who have distal disease. Patients who have subsegmental pulmonary embolism often go undetected on CT, and a VQ scan is extremely helpful in demonstrating perfusion mismatch compared to ventilation in these patients. So another modality which helps us in assessing these patients better. Cardiac MR is a great modality when it comes to assessing patients with pulmonary hypertension, especially CTEPH. In cardiac MR, you can get a pulmonary angiogram very similar to CT, and you're seeing one such angiogram here. MR is also useful in looking for perfusion of the lungs, as is seen in this case, where as the contrast comes into the system, you can see the upper lobe is well perfused, while the middle lobe and the lower lobe are not that well perfused at all. This again helps us in determining the distal disease in these patients. Cardiac MR is extremely useful in assessment of the right ventricular function and volumes, because these have got significant prognostic implication in these patients. For example, if you see a patient who's got the end diastolic volume of RV is increasing, or the end systolic volume is increasing with reduction in the RV function, it all signs to a poor prognostic feature in these patients. Now, the most important topic is the management of these patients. The first and foremost thing is confirmation of CTEPH using multimodality imaging. We prefer to have at least 3 modalities confirming what we have seen. So for example, if there is a CT which shows CTEPH, we would do a catheter angiography plus or minus a VQ scan plus or minus a cardiac MR study to confirm the disease and to assess the extent of disease, because this is very, very important before we offer them any curative surgery. Second thing is to locate the disease and to estimate the disease burden. If you have disease which is in the central part of the lungs, such as lobar level or in the main pulmonary artery or in branch pulmonary arteries, then surgical option of pulmonary endotherectomy is preferred. If you are seeing disease which is very distal in location, subsegmental, then we do offer them pulmonary angioplasty. You at least need 5 or more segments to be involved before you do any surgical therapy for these patients. Anticoagulation is something which they have to be on lifelong, irrespective of whether they have surgery or they have a angioplasty. Pulmonary endotherectomy is a surgery which is done in some of the specialist units around the world. We happen to be one such unit where there is an incision made into the pulmonary artery and the clots are removed en masse from the pulmonary artery and its branches. Pulmonary angioplasty, on the other hand, is like a coronary angioplasty where balloon is used to break through some of the webs and open up these pulmonary arteries. Finally, medical management. Newer drug therapy, one such drug called as riociguat, is also very popular in managing patients who are not fit for a surgical correction. This is what pulmonary endotherectomy sample looks like. So if you've got a type 1 disease which involves the proximal pulmonary arteries, this is a clot removed from either side of the lungs. You can see it forms a cast. These are things which go inside the pulmonary artery and block the pulmonary artery. So you can see this is type 2 disease, where the disease is a little bit more distal, and this is type 3 even further, and they often tend to be very difficult in operation. Type 4 diseases, where it's the vessels which are at a capillary or just before the capillary level which have the problem, and often they are a surgical nightmare, and the results are not that great. So type 1 to type 3 disease are what we would like to operate and get rid of the clots. If you are starting to see distal disease, pulmonary angioplasty is an option. So you can see here, this is the patient where you're seeing the vessel and it just blocks off. There is no flow distal to it. We've managed to pass through a guide wire. Then we've done a balloon angioplasty of this. And following that, you can see we've opened this whole blood vessel. All is not very easy. Sometimes you will get surprises, like one such case is here, where you're seeing calcification and you're seeing distal vessels. You would agree to me that this could be a chronic pulmonary embolism, but this turned out to be pulmonary thromboemboli in situ. This is an entity which is seen in severe PH, and there is secondary thrombotic disease, just like the aorta, where the pulmonary arterial pressures are so high that there is atherosclerosis. This is an entity which should not be operated. Patients will not recover from the surgery. So if you're seeing grossly dilated pulmonary arteries, non-occlusive thrombus, the vessel has got disease but there is non-occlusion, think about in situ thrombosis. Another entity which you may not come across that easily is very good mimic of pulmonary embolism is this, where you're seeing a large hypodense filling defect, often central in location, which is expanding the vessel. It is useful to do a slightly delayed run in these patients and to see if you can demonstrate any enhancement of the walls of this lesion, which you can see across here that there is enhancement towards the periphery of the lesion. This is an example of pulmonary angiosarcoma. One more surprise that you may come across depending on which geography that you live in are filling defects within the pulmonary artery, with some further filling defects in the right heart also. And you think, okay, this is all pulmonary embolism, but when you do an MRI scan, you are seeing these large cystic spaces within the right heart, and again some cystic spaces in the lungs. This was a case of hydatid cysts which are embolizing into the pulmonary vasculature. So, in summary, PH is different from pulmonary arterial hypertension, and CTEPH is actually pulmonary hypertension and not pulmonary arterial hypertension. Second, on CT, look for collaterals, look for webs or filling defects where the vessels have become smaller, look for bronchial artery collaterals, and look for right ventricular morphology, helping you in deciding between acute and chronic pulmonary embolism. Multimodality imaging is extremely useful and is required before a corrective surgery is provided to these patients. If the patient is not fit for surgery, pulmonary angioplasty can also be performed in these patients. Beware of surprises. You would see some unusual cases once in a while, but as long as you're aware of these, you will not make the mistake. Thank you very much for listening in. For more educational content, I would request you to subscribe to my YouTube channel